discussed many things. We had discussed many things about the ARDS. So we had discussed about the definition, pathology, diagnostic criteria. So in case of a diagnosis, which type or there are many we can call as a European Respiratory Committee, ERS, like so many different associations have diagnosed based on particular particular criteria to diagnose ARDS on the basis of gases exchange, on the basis of PaO2, ABG. See, ultimately, any diseases, when patient, any respiratory disease or multi-organ failure or septicemia, ultimately patient will die because of respiratory failure. Suppose when there will be a embolism, pulmonary embolism or heart failure, and because of that pulmonary edema will be there, or maybe pneumonia was there, or pleural effusion, pericarditis, myocarditis, anything will be there, or COPD or corona or any restrictive disease. Ultimately, a patient will fail because of respiratory failure. And what is respiratory failure? In the one terminology, one sentence, if we tell, see, we are giving oxygen. See, in the atmosphere, presently, we are having 21% of oxygen concentration, isn't it? But in the oxygen therapy, we are giving more than that. We are giving 23%, 30%, 40% of oxygen. Yes, no. Ultimately, what? To increase the PaO2. The normal PaO2, you know very well. 60, 65 mm of Hg. Or we can call as what? In the 1 atmospheric pressure, 760 amount of environmental pressure, 760 mm of Hg. What we are having the pressure inside our alveoli, that is what your PaO2, not SpO2. And PO2 normal will be 60 mm of Hg. So as it goes down, as it goes inside the blood and reaches to the cell, it decreases. When the PaO2 is decreased, partial pressure of oxygen decreases, the affinity of hemoglobin in oxygen decreases. So automatically hemoglobin will leave the oxygen molecule, or hemoglobin and oxygen will be disparted, or they will be not combined. So ultimately oxygen will be taken by the cells, and carbon dioxide, the partial pressure of the carbon dioxide will be high at the cellular level. So what will happen? The hemoglobin will catch the CO2, carbon dioxide, and take it away. Yes, so this is the scenario. So when you are delivering more amount of oxygen, and even though we are unable to maintain the PaO2, why we are unable to maintain the PaO2? Because whatever you are giving, whatever the concentration you are delivering, it is not has been reached to the capillaries. Whatever you're delivering to the mouth, to the trachea, but when it reaches to the alveolar level, there may be an obstruction, there may be a secretion will be present, or there may be a alveolar capillary network will be inflamed. So many problem will be there. So many debris will be there, pus formation will be there, secretion will be there. Ultimately, the alveoli is unable to deliver the gas, unable to go for gases exchange properly to the capillary level. So ultimately what will happen? You will unable to maintain your PaO2, partial pressure of the oxygen, at the level of the capillary. Yes. So what they say, many diagnostic system, many diagnostic criteria they have found by FiO2 is less than 300, it means acute lung injury. If it is less than 200, it means ARDS. This is the one criteria you should know. Huh? Are you getting all of you students? One criteria you must know. What is acute lung injury? It is a less severe form. If it is less than 300, PaO2 is more, it is what? ABG. You are taking the arterial blood and going for the arterial blood gas analysis. In that you will get the partial pressure of the oxygen. That value you will put. And how much amount of concentration you are delivering. You are delivering 30%, you're delivering 40%, 50%, or 60, 70, whatever it is. So ultimately, when you're going for this calculation of PaO2 by FiO2, if you are getting less than 300, it means what? You are going for acute lung injury. Patient is having acute lung injury. So there will be inflammation, we can call as a pus formation or rupture. Because of that, the oxygen is not delivering from alveoli to the capillaries. Alveolar capillary disruption will be there. And if it is less than 200, it means patient is having ARDS. Because of any condition. Are you getting my point? See, in the typhoid, malaria, cholera, or corona, any disease, you will get fever. Same way, in respiratory condition, you'll be having a restrictive disease, obstructive disease, corona, or any pneumonia or anything. Ultimately, when because of inflammation, when the we can call as a inflammatory reactions are very high against our anti-inflammatory system. When our anti-inflammatory system is not able to subside the inflammation, it will be very high, and that may destruct the alveolar capillary network, interstitium. And ultimately, because of that, what will happen? You will unable to maintain your PaO2. So when you calculate your PaO2 by FiO2 less than 200, okay, patient is having the ARDS. Are you getting my point? So I want to make you again see this PPT, how to diagnose the ARDS by American European Consensus Conference and the Johnson criteria. See, John's criteria is for rheumatic fever, rheumatoid arthritis. Here it is Johnson's criteria. Johnson criteria is for ARDS. So it is acute bilateral infiltrate, you can see in the X-ray. It is non-cardiogenic pulmonary edema. Pulmonary edema is present, but the problem, the cause is not cardiac origin. Most important thing is this: when your PaO2 by FiO2 is less than 200, it means patient is having a ARDS. If it is less than 300, patient is having a ALI. Yes. Okay. With that, you can see purulent sputum, fever, and high amount of the WBC in your blood or in the sputum. Yeah. This indicate patient is going for ARDS. So many different authors have made their diagnostic criteria and definition of ARDS. Some says severe dyspnea, tachypnea, cyanosis, pulmonary compliance decreases. Both the lungs, you can see the alveolar infiltrate pneumonia in the chest X-ray, atelectasis, venous congestion. Some says indirect lung injury, mild to moderate severe lung injury, non-pulmonary organ dysfunction, septicemia may be there. So different authors, they will say different things. But the ultimate criteria is what? PaO2 by FiO2. If it is less than 300, it is acute lung injury. If it is less than 200, means acute respiratory distress syndrome. Yes. So radiological exclusion and oxygenation. With this, you can diagnose the ARDS. Yeah. Ultimately, it is the same thing. PaO2 by FiO2, regardless of the PEEP. Okay, I think you know about the PEEP. We'll discuss later about PEEP also. Whatever you are going for PEEP, the PEEP will be will start from the 5 mm of Hg, or sorry, centimeter of H2O, 5 to 10, and most cases we can go for 10, 15 centimeter of H2O PEEP. What is PEEP? We'll see it later. Here it is criteria for acute lung injury. Again, less than 300. If it is very severe case, less than 200. You can see in the X-ray bilateral infiltrate. Pulmonary artery wedge pressure. If you see, it is less than 18 mm of Hg. No arterial hypertension. Not because of atria, not because of heart. Pulmonary capillary wedge pressure is there, but not because of heart. Yes. What is entry criteria for EC, ECLA therapy, according to Zelopeter? So how we can go for, okay, the patient is having this thing. So it is more of a physician related this thing. The PaO2 is less than 50 mm of Hg with the FiO2 1. PP will be more than 5 cm of H2O for more than 2 hours. You are not maintaining your PaO2 at the level of the 60 mm of Hg. With the FiO2 will be 1 liter, even though you will unable to maintain the PaO2 60 mm of Hg. It is less than 50. It means you need to go for ECLA therapy. Yes. Then slow entry. Fast entry means immediately you need to go. Slow entry. Okay. You can go for FiO2. 0.60 means 60%. When the PEEP is more than equal to 5 cm of H2O. So QS and QT, it is ventilator, this thing, ventilator diagnostic criteria when the FiO2 is 1 liter for more than 12 hours. So slowly it is going for that. So it is a therapy where we can go for one thing. Yeah. So ultimately, the thing is more of a protein-rich fluid will be sipped. So as we had discussed last class, that when there will be an inflammation, when there is an inflammatory stimulus, there will be increased permeability. And when there is an increased permeability, what will happen? More of a protein-rich fluid will come inside in between the alveolar capillary network. Ultimately, there will be a coagulation. There will be a there should be a fibrinolysis, but the fibrinolysis will not happen. And ultimately, in case of ALI and ARDS, there will be more of a fibrin-rich network formation. And ultimately, you'll be having a fibrosis, pneumonitis, and ultimately you will get decrease in your compliance level. Person is unable to inhale deeply. Yes, so this is the thing. Okay, why this happen? Why ARDS will happen? That is because of the two things. First is primary lung disorders. As we had discussed, patient was in a pneumonia, or you may go for some aspiration, some burns or inhalation injury, or drowning. Drowning means falling into the well or in the sea. So what will happen? Infected fluid will go inside the lungs. Then contusion, maybe trauma and leads to infection. Or maybe septicemia, burns, shock, or pancreatitis, etc. Many things. The systemic disorders can also go for the. Suppose you see, when there will be a kidney failure. See, because of kidney failure also, there will be a peritonitis, urinothorax. Ultimately, because of the peritonitis, there will be an inflammation, and there will be a fluid inside the pleural cavity, that is urinothorax. What is the urea content will be present inside the pleural cavity, that is called as the urinothorax. So you have heard about the pleural effusion, hydrothorax, hemothorax, but urinothorax also may be there because of this. So ultimately both are interconnected. Abdominal cavity and thoracic cavities are interconnected. So anything happen in the abdominal cavity, any abdominal infection may lead to lungs infection also. Yes, because of increase the permeability. Are you getting my point? Yes, so these are the causes. What are the predisposing factor? What is predisposing factor? Anyone? Huh? Predisposing means if these are the cases will be there, these are the people are high chances or likely to go for ARDS. Like advanced age, aged people, more of alcohol abused, those who take more of alcohol, immunity will go down. Lung cancer, as in each and every cancer, the lung or all our immunity will go down. Fluid overload or any radiotherapy patient is taken, chemotherapy is taken, so ultimately immunity was low. Huh? Any prior old heart and lung diseases, or any lobectomy have been done, pneumonectomy, partial pneumonectomy has been done, yes, or transfusion of a frozen fresh plasma. There may be n number of cases to have a lung infection. Volutrauma, barotrauma, because of the this is the complication of the ventilator. Mechanical ventilator, when you're applying positive pressure, there may be a more of a volume will go inside the lung, so there will be a stretching, and because of pressure also. So volutrauma and barotrauma both will happen. Volutrauma is because of more of a volume, alveoli will be stretched, and barotrauma you are giving high pressure. So because of that also there might be a injury. Bronchial aspiration. What is aspiration? The fluid should not go inside the lung. But in any case, when the infected fluid will go inside the lung, then they cause infection. Then some mechanical factors like lymph vessels, or lymph vessel is not properly draining the fluid. Yeah. Or there might be so many different reasons. Ultimately, increase the permeability. This is the one cause what I feel. Because of whole this thing, what will happen? Increase the permeability of the alveolar capillary membrane. And because of this, lots of protein-rich fluid will come inside the alveoli. Yes. And if you are giving very high concentration of the oxygen to the lungs, ultimately that also causes the oxygen toxicity. So you can go for oxygen therapy. What is oxygen therapy? You are delivering the oxygen more than 21%. You go for 20, 30, 40, 50 is fine, 50% is fine. But see, in case of those people who don't know how to give oxygen therapy, they will give 100% of the oxygen for a continuous long period of time. They can cause oxygen free radical. More of oxygen free radical will be there, and they will rupture, and they will again cause the inflammation. See, do you know when we will give 100% percentage of the oxygen concentration? In the room level, we are delivering only 20%. In the oxygen therapy, when surgery will happen, we will provide 30, 40, 50%. But when we can give 100% of the oxygen, do you know that? Huh? Okay, those who have attended the ICU, those who have posted in the ICU, they have come to know that when the patient need to go for the suction, when the patient is having a pneumonia and we need to aspirate the secretion, unwanted secretion was present and we need to remove it. That time what will happen? Before going for suction, we need to hyperventilate the patient so that patient don't saturate, desaturate. So for preventing the desaturation, just before the suction, we will give 100% of the oxygen for 1 minute. So what will do? Patient will be on the endotracheal tube, or patient will be on the tracheostomy tube. We will give 100% of the. So when you press the button inside the ventilator, that 100% of the oxygen, so automatic that the ventilator will provide 100% of the oxygen for 1 minute. Just after the 1 minute, it automatically switch over to the 30, 40 or preset level. Just immediately we have to disconnect and you have to go for suction. Yes. So after the suction finishes, if patient continuously desaturate, then again 1 minute we can go for the 100% of the oxygen, and again we can switch over or we can reset to the 30 or 40% of the preset level. So here only we will give 100%, otherwise not. Yes, is it fine? Okay, see, we can go for some another criteria to go for to know about the acute lung injury in ARDS. So what is ALI? Again, acute onset, both are acute onset. One criteria you know very well, PaO2 by FiO2 need to be less than equal to 300. Yes, but if it is less than 200, we can say that it is very severe form ARDS. One more criteria, SpO2. What is SpO2? What you are checking in the pulse oximetry, which is not that much reliable. But if you go for SpO2 by FiO2, if it is less than equal to 315, you can say it is milder form, it is acute lung injury. But if it is less than equal to 235%, or there will be no unit as such when you go for division, and you will get 235, it means it is a very severe ARDS. See, in both the cases, you will see bilateral infiltrate on the frontal chest radiograph. Patient will be in the supine line. When we go for AP or PA, you will see bilateral infiltrate. Pulmonary capillary wedge pressure will be less than 18 mm of Hg. Yes, here there will be no clinical evidence of left atrial hypertension. But in the ARDS, again, you will not see any evidence of left atrial hypertension. Non-cardiogenic pulmonary edema. Yes, if you go for the pulmonary capillary wedge pressure, it will be more than that, more than 18 mm of Hg. It means it is what? Pulmonary hypertension. Here it is high, but not because of cardiac origin, because of pulmonary origin. Is this fine? See, both the criteria are same, but only PaO2 by FiO2 and SpO2 by FiO2 will be different. That we need to know about that. Yes. So see what will happen. Mild, moderate, and severe. See, we are going into the depth. Okay. See, we are going for this criteria. What will happen in case of a lung compliance, hypoxemia, endothelial cell, interstitium, and epithelial cell? See, lung compliance means ability to expand. Lungs ability to expand is what? In mild, moderate, and severe. Okay, severe means ARDS. Okay, second thing is hypoxemia. What is hypoxemia? Decrease oxygen level in the blood. Okay, decrease oxygen level in the blood. Hypoxia means decrease oxygen level in the cell level. Okay, so what will happen to all the various levels? Then endothelial cell. So whether the cells are going for inflammation or what? So gradually mild to moderate and then severe. Okay, what will happen to the interstitium? Interstitium means alveoli and capillary network. The permeability increased, too much of increase, metabolic dysfunction, and very severe. And endothelial cell. So there will be a type 1 and type 2 cell. So when there will be a mild to moderate, if you go, the severity will increase and increase and increase. Isn't it? Yes. So you see, lung compliance will be there, will be very mild. Moderate, significant increases, early ARDS, and very severe, late ARDS. Lung compliance will be severely decreased. Non-PEEP responsive. Okay, can anyone tell me what is PEEP? Anyone? Can anyone tell me what is PEEP? Okay, fine. We'll discuss it later. You think about that. Okay. So hypoxemia means very less amount of oxygen in the blood. So in the mild ALI, O2 is responsive. We are giving oxygen therapy, it will improve. Here, when you are going for a PEEP, oxygen level will improve. Here, when you are going for oxygen therapy and PEEP, it is not responsive at all. It is called as a very severe. Interstitium, in the mild ALI, permeability will be increased. Here, metabolic dysfunction 1+ level, and here metabolic dysfunction 4+ level. Epithelial cell edema, edema will be increased and very increased edema. Type 2, there is no problem. Here, sloughing and hypermitosis and sloughing metabolic consolidation will be increased. This is a sign of pneumonia will happen. Sloughing means the debris will be there. Epithelial cell will be inflamed and it will be washed out. That is called as a sloughing. Yeah. Now you see. There will be a two type of acute respiratory failure, ALI, acute lung injury. What will happen? You see, there will be a main two type. One thing is hypoxemia, and another thing is hypercapnia. So what is hypoxemic? Hypoxemic means when you go for the assessment of the ABG, arterial blood gas analysis. See, when patient is in ICU, when patient you are suspecting ARDS, what will happen? Either you will get less amount of the PaO2. When you will get less amount of the partial pressure of the oxygen, you can tell it is hypoxemic. But when there will be a normal amount of the normal or decreased amount of the PaO2, but very severe form of PaCO2, partial pressure of the CO2 will be very high. That is called as a hypercapnic. Are you getting this? Hypoxemic means PaO2 is decreased. Hypercapnic means PaCO2 is increased. So for both of these things, the cause may be different. Yes, cause may be different. We'll discuss now. So what is hypoxemic? Where you'll be having a PaO2 is decreased. How the PaO2 will decrease? Because of first pulmonary edema, because of pneumonia, because of acute lung injury, because of septicemia, because of aspiration, because of lung injury, contusion, acute pneumonitis, maybe corona, pulmonary embolism, or maybe anything else. This is the problem of lung. Because the lung is not properly working, this is called as a hypoxemic. PaO2 is less. But when the PaCO2 is increased, when your pump is not working, what is pump? Diaphragm. Diaphragm is a pump. When diaphragm cannot work properly, when you have taken too much amount of respiratory depression drugs, morphine, pethidine, these are the respiratory depression. As CNS depressed, respiratory also suppressed. Ultimately, you will be having a CNS depressant. So CNS depressant means it will not stimulate the phrenic nerve. When phrenic nerve will not work properly, CNS depression, respiratory depression, you cannot deep breath. Again, brainstem injury, high spinal cord injury, phrenic nerve neuropathy, neuromuscular junction problem with the diaphragm, diaphragm myopathy, or kyphoscoliosis. Because of the restrictive disorders, you will get not proper amount of the working, that is hypercapnic. You'll be having more amount of the carbon dioxide. High amount of carbon dioxide, more amount of the respiratory acidosis. That is because of decreased pump failure. Now, what is increased load? When the COPD will happen, asthma, cystic fibrosis, or bronchiectasis, where the pump is normal, lungs are normal, but the ability to contract the muscle is not normal. Muscle fatigue will be there, and because of that you'll be having increased the load, and because of, again, there will be hypercapnia. So whether the patient will go for hypoxemic or because of hypercapnic, PaCO2 is down or PaO2 is down or PaCO2 is increased. And because of these two conditions, you will get the acute respiratory failure, ALI or ARDS. Yes, are you getting, student? Is this fine? Are you getting this? આ સમજાય છે?
Yes, sir.
Yes.